Good morning again, and we continue the session of this morning. And the speaker will be Bob Kakmarek. He's a professor and a director of respiratory therapy in Massachusetts General Hospital. Dr. Kakmarek has been in China in recent 3 years several times. And for Chinese audience, we are somehow familiar with, but for the international guests here in this audience, I think we should look forward to your second talk.
Thank you very much. In this presentation, I would like to take a very practical approach to the issues and problems that all of us encounter as we try to perform non-invasive ventilation on the myriad of patients now that the literature supports the use of non-invasive. And I would begin this discussion by rapidly reviewing the list of indications as I see them. Just one slide, but trying to put into focus where I think the literature points out those types of patients we should be using non-invasive ventilation as first-line therapy, those that there is reasonable data to support consideration of non-invasive, and then probably most importantly, the ones that there is a fair amount of controversy over the use and where I would inject a word of caution as you apply non-invasive ventilation. But clearly, in patients with chronic obstructive lung disease, cardiogenic pulmonary edema, the evidence is becoming almost overwhelmingly in favor of non-invasive as the first strategy to manage these patients. Clearly, there is at least one randomized controlled trial that deals with these aspects of applying non-invasive ventilation: hypercapnic respiratory failure post-extubation, hypoxemic respiratory failure in very specific sets of circumstance. No randomized trials, but very large case series, especially in patients with neuromuscular neurologic disease. We have a very large ALS clinic, for example, and we start patients very early on the use of non-invasive ventilation, and those patients developing acute problems, again, using it on a frequent basis, and at least some case series data pointing to the use in select patients with do not intubate, do not resuscitate status. But in these patients especially, I think the literature supports that word of caution, that we need to be careful with the application and err on the side of going rapidly to intubation if patients do not respond quickly, which I will talk about in a little bit more detail as we continue. One of the things that I stress to my staff that I think is very important as you try to apply non-invasive ventilation to a patient in acute respiratory failure is a sensitivity to what that patient is experiencing and what you're trying to do to that patient. If you haven't had non-invasive ventilation applied to you and you are actively utilizing this technique on patients, I would recommend that you try it on yourself. Now, I say that because it is difficult, even for an individual knowledgeable about the application of non-invasive ventilation, to accept on the first breath when somebody takes the ventilator, sets it at 5 centimeters of water PEEP, 10 centimeters of water pressure support on top of it, and immediately straps a mask to your face, and you have to accept that gas delivery on the first breath. Consider the patient that you're doing that to. This patient is in acute failure, is very dyspneic, is essentially afraid that they're going to suffocate and die because they can't ventilate. And the last thing they want is somebody to come and strap a tight-fitting mask to their face. So being sensitive to that and the approach of taking the time to educate the patient, being supportive of the patient's concerns and issues, can make a big difference in the way that non-invasive ventilation turns out in a given set of patients. I very strongly believe you cannot sit down and come up with a basic set of parameters that are going to work on every patient, that you have to do the titration to the individual patient to see what will meet your therapeutic needs as well as what that patient will actually tolerate as you apply it. I try to get my staff to begin with very low settings on all the variables involved. and not to strap the mask, but to allow the patient to hold the mask or to hold the mask themselves so that the patient can be interrupted for short periods for questions or issues as they start to acclimate to it. Once they start to accept the process of the non-invasive ventilation, then to slowly increase the settings until you achieve your therapeutic objectives. And I would say in the vast majority of patients, you can establish ventilation with peak pressures of 20 or less, and in most patients, at least those without hypoxemic respiratory failure as a primary indication for non-invasive ventilation, relatively modest levels of PEEP seem to be effective. I would keep in mind that we're not trying to achieve huge tidal volumes. We're simply trying to reestablish the tidal volume that would be normal for this patient. And I try to emphasize the fact that these patients rarely are going to have lengthy inspiratory times. Most of them will ventilate with very rapid inspiratory times. And as you look at the response of the ventilator, as we'll talk about in a second, and if inspiratory time is prolonged, we should look for a reason for that, because most likely the patient is not going to choose a ventilatory pattern with a 1.5 seconds or a 2-second inspiratory time. There may be a technical issue that is associated with why that inspiratory time is lengthened. Now, obviously, success is very easy to identify. We begin this on a patient who is hypercarbic, who is acidotic, who is hypoxemic, and an hour or two later, all that's turned around and everything looks wonderful. Unfortunately, that's not the common response that we see. It may take some time for us to show a dramatic improvement in the patient's overall clinical status. The set of circumstances that I worry about most when we initiate non-invasive ventilation is a patient who does not respond with a change in their cardiopulmonary stress. They're still tachycardic, their tidal volumes tend to be small, hemodynamically they're still unstable, they're using accessory muscles. You take a blood gas after a couple hours and you do not see a significant change in that patient. That's the patient where you really have to sit back and say, am I doing this patient a disservice by continuing non-invasive ventilation, or is this the patient that we need to intubate and maintain invasively? I would recommend erring on the side of intubation, particularly if that patient has a primary problem of hypoxemic respiratory failure, and specifically if it's just general acute lung injury, ARDS. We have seen too many instances in our own institution as well as in the literature where we've prolonged the process of non-invasive ventilation in these patients, and at the time of transitioning them to intubation, we've had a patient go into a cardiac arrest, where by eliminating non-invasive ventilation, rapid fall in airway pressure, the loss of the extra oxygen that the patient's receiving, and the process of intubation, we have had patients, arrest on us. So I would be cautious. In these kind of patients, I clearly would be much more cautious with accepting failure than I would with the COPD patient. The COPD patient, I would push the process a little bit longer, but these are the ones that I think in the literature supports a very cautious approach to accepting failure of non-invasive ventilation. Now, as far as technical issues, obviously any mechanical ventilator ever developed can be used to do non-invasive ventilation. However, there clearly are ventilators that would allow us to do it more efficiently and those that would not. Two groups that most of us use: those ventilators that are designed for non-invasive support, or the ICU ventilators that we have available in all of our units. First, let me make a couple comments about this group of mechanical ventilators. At least in the literature that's been published comparing operational capabilities, gas delivery capabilities of these units, they clearly are at least as responsive as ICU ventilators. They're capable of meeting patients' ventilatory demands. Most have peak inspiratory flow capabilities of up to 200 liters per minute, at least as good as the ICU ventilator. Most transition to exhalation quite well and are able to compensate for leaks. And this is probably the key advantage of this group of mechanical ventilators. All of them are designed to compensate for the leaks that do occur anytime we provide non-invasive ventilation. What they don't do as well as a typical ICU ventilator, at least as a group, is allow you to adequately monitor patients. Some are very poorly alarmed, although I would not say we need extensive alarming on these ventilators. But when they're used for life support, we should know if there's a disruption in the circuit. There is always the potential of CO2 rebreathing, and we'll get into that in a little bit detail in just a second, and most of them do not allow you to deliver very specific and consistent FiO2s. And I'll show you some data we published as we continue on that. But one of the big disadvantages is that in most of these ventilators, you cannot see waveforms on the patient during non-invasive ventilation. Now, this is a patient intubated receiving pressure support ventilation, and as you can observe, a tremendous amount of dysynchrony. Well, the same level of dysynchrony can exist with patients receiving non-invasive ventilatory support. Now, without some visual feedback on how well we're delivering that non-invasive ventilation, we can make some assumptions that simply are not consistent with the reality of the way that patient is actually being ventilated. So I would be cautious in the intensive care unit in acute failure to choose a device that doesn't give you some feedback from a visual perspective on how effective you are in matching gas delivery to meet the patient's overall ventilatory demand. This was from a publication now over 10 years ago that looked at the impact of CO2 rebreathing with these bi-level pressure ventilators. Remember, every one of them that I'm aware of on the market has a single limb gas delivery system. Exhalation occurs through some small orifice somewhere in the mask or in the tubing itself. These ventilators have very low internal resistance. So if you have very low level or zero PEEP set on these units, it is possible exhalation can move retrograde all the way through the tubing back to the mechanical ventilator, and of course allowing CO2 to be inspired on the next breath, which is exactly what this group showed with a series of ventilators. Here you see normals or patients. This is with the typical single orifice expiratory port in the system, and both of them significant CO2 rebreathing. When isolation valves were added or when actual exhalation valves were added to the system, the CO2 rebreathing was eliminated. The other factor that eliminated it was adding PEEP to the system. Now, almost all of these ventilators on the market today do not allow you to set them at 0 centimeters of water PEEP. You may go to the minimum level, but if you actually measure what's going on, they maintain 3 or 4 centimeters of water positive end expiratory pressure, even at their lowest setting. The reason for that is to avoid CO2 rebreathing, to allow a consistent flow towards the patient during the expiratory phase so you don't get retrograde movement of exhale gas and you don't see CO2 rebreathing. So always consider this a possibility in patients that are difficult to ventilate unless you have 5 or 6 centimeters of water PEEP applied to the system. In acute respiratory failure, as I think I've made it clear in my previous comments, the ventilator should be designed for use in the ICU. We should be able to monitor the patient carefully. It should be appropriately alarmed. It should provide accurate and high FiO2, essentially designed to treat the type of patient that you're applying this particular ventilator to, which is why many centers utilize ICU ventilators, because they are designed from that format. And of course, there's an increasing number of ICU ventilators that have added non-invasive modes to their overall operation. Now, that non-invasive ventilation package that exists on these ventilators is very diverse. There is not a consistency across mechanical ventilators. Some of them allow you with this package to turn off alarms that you would not be able to turn off during invasive ventilation. Some will compensate for leaks during triggering to the inspiratory phase. Some will compensate for leaks during cycling to exhalation. Some will compensate for leaks on both sides triggering and cycling. You really have to look very carefully at what the package provided by the particular mechanical ventilator is to determine how effective that non-invasive ventilation package on the particular unit that you're using. In general, I would say that you have to be careful with the type of interface that you use. Nasal masks and the oral facial masks that have leak ports built into the mask or have one-way valves that are used for allowing the patient to breathe to atmosphere if the tubing should become disconnected, as exists for many of the bi-level pressure ventilators, tend not to work well with ICU ventilators. You have to use a mask that has no expiratory port on it, no one-way valve in that mask for it to function with maximum efficiency with an ICU ventilator. The big problem with these units is cycling to exhalation, and I'll talk about that in detail. However, alarm packages could or could not be designed for non-invasive ventilation depending upon their addition of these non-invasive modes. They do monitor patients well. Clearly, they are alarmed to meet the needs, and they do provide very precise and consistent FiO2. So there's pluses and minuses with both of these units. With non-invasive ventilation, one of the things you should be aware of in that transition from inspiration to expiration is an increase in pressure in the system as exhibited here during pressure support. This is actually a pressure support breath in a patient who is intubated, but the same phenomena occurs in non-invasively ventilated patients. We should see a smooth transition to the expiratory phase and not this spike. When that spike occurs, Martin Tobin's group has very nicely showed in a series of articles that the patient is starting to exhale at this point in time, but the ventilator is not allowing exhalation to occur until this point in time. So you have patients activating accessory muscles of exhalation, essentially activating abdominal muscles to force exhalation to occur because the machine is not cycling on its primary expiratory variable. And that primary variable, as you well know, is a decrease in flow to some specific percentage of peak inspiratory flow. Most ventilators have used 25% as the default criteria to allow transition to exhalation, which has worked very well in patients who were intubated and mechanically ventilated. But if the patient non-invasively chooses to end the breath at a flow rate that's higher than that 25%, what you will see is the patient forcing exhalation to occur. And if I can go to the next slide, forcing exhalation to occur by cycling with the secondary criteria, which is an increase in airway pressure after so many milliseconds into the breath of a certain number of centimeters of water. And every ventilator uses a different algorithm to figure that out. But every single ventilator on the market that allows pressure support as a mode of ventilation has an excess pressure at the end of the breath as a secondary cycling mechanism. And that's what you'll see happening frequently in these types of patients. Just to be complete, there is a third level, and it's a lengthy inspiratory time, 2 to 3 seconds in some ventilators. Now, one of the things I did not mention with some of the non-invasive ventilation packages on ICU ventilators, they do allow you to set a maximum inspiratory time during pressure support, which is clearly a very useful adjunct to the patient who is being non-invasively ventilated. So you can either end the breath when flow decreases to the predetermined flow rate, or when inspiratory time hits that setting of whatever you have. What I usually instruct my staff is to set that inspiratory time at about 1 second, so that the patient, if they don't cycle off with a diminished flow, at least after a second, there'll be a transition to the expiratory phase. I wanted to go back to this slide because many of the newest ventilators on the market allow you to vary that termination criteria. Very useful during invasive as well as non-invasive ventilation. So if the patient has difficulty cycling the breath, all of these ventilators, and this is just a snapshot of the ventilators out there. They change so quickly. I'm sure there are more that I don't have listed here who have this capability, but it allows you to change this percentage over a wide range. Some of them will go from 5% up to 80% of the peak flow. And if we simply look at this depiction, this is what is essentially happening. If we set that termination criteria at 10%, that means that when the peak flow drops to 10% of that maximum level, the breath will end. If I set at 25%, when it drops to 25% of the maximum level, the breath will end. Or at 50% of the maximum level. So if the patient chooses, as many stress patients do, to end the breath while inspiratory flow is still very high, with this option, we should be able to adjust in order to allow the ventilator to coincide ending the breath with the patient's desire to end the breath. Now, of course, this requires you to be observant and pay attention and to readjust this. My guess is that the next generation of ICU ventilators we will see, this will be automated, that they'll be like the non-invasive ventilators, a change in the level consistent with the ventilator's interpretation of the patient's transitioning to the expiratory phase. We can do it by looking at waveforms. The ventilator can easily determine that the patient wants to exhale before the ventilator is ready to exhale. And I would expect that, again, this would be automated as time goes on. Just for completeness, in intubated patients, you can see the opposite phenomena occurring. In other words, the breath ending too soon, too high a termination criteria, which gives you this appearance of two breaths, one right after each other, on the flow, as well as a secondary bump in pressure here on the airway pressure waveform. In other words, the breath from the ventilator's perspective ended here, but the patient kept inhaling, and they actually went into the expiratory phase at this point in time. So it almost looks like there's two breaths being administered. And as you'll note here in this example, in decreasing the termination criteria to 5% totally eliminated those issues on the airway pressure as well as on the flow curve. So I think it's a very useful adjunct to allowing you to customize that pressure support breath to the desires of the patient at a particular point in time. This is from an old study now, well, old, 7 years old, in which patient was ventilated here with pressure support on an ICU ventilator that did not allow you to adjust the termination criteria. And what this group did and what they recommended, and which I would recommend, is transitioning the patient from pressure support to pressure assist control, where you actually set the inspiratory time consistent with the patient's inspiratory time. Now, obviously, if you had the ability to set termination criteria, you could bring this patient in phase with the pressure support. But without that, simply changing to pressure assist control. I think it's important to keep in mind that on every ventilator on the market, at least that I'm aware of, the algorithm for gas delivery in pressure assist control and pressure support is the same. The only thing that differs is how the breath ends. Now, in pressure assist control, we can put a backup rate, which you can't with pressure support. But other than that, one ends the breath primarily by time, pressure assist control. The other ends the breath primarily by a decrease in flow, pressure support. So if pressure support isn't working and you have one of these ventilators without termination criteria, consider same exact pressure setting in pressure assist control, adjusting again the inspiratory time to meet the patient's actual desired inspiratory time. Humidification. It took us a long time, and I'm not sure why it did, to recognize the fact that with non-invasive ventilation on most patients, we do need to humidify that gas delivery, particularly if we're using high FiO2s. We have now mounted heated passover humidifiers on all of our non-invasive ventilators, so that regardless of whether we're doing non-invasive CPAP for sleep apnea or we're using non-invasive ventilation for patients with an acute exacerbation of COPD, we do provide that adjunct humidity. What it's eliminated is having to intubate patients because of a significant accumulation of dried retained secretions in the back of the oral pharynx. We had a number of circumstances where I was getting reports that we had to intubate, and when we did, McGill forceps, they needed to pull out this thick secretions accumulating in the back of the pharynx. That was eliminated once we added active humidification to all of our mechanical ventilators. At least that, as a reason for failure, was gone. Now, it's difficult to know how to set these. As you see, I've got about 30 degrees centigrade. We set it to patient comfort. You can use a heated single-limb circuit in your non-invasive gas delivery system. If you're using an ICU ventilator, even easier, because you can use the typical heated circuits to avoid this problem, or active humidifier without a heated circuit, although you have an issue with accumulation of secretions. I put here a question mark about using heat and moisture exchangers. Now, I say this because, remember, a heat and moisture exchanger, for it to function properly, you have to exhale through it and then re-inhale through that. With non-invasive ventilation, the volume moving back and forth can be quite different on each breath, as well as between inspiration and expiration, as a result of leaks. And if you're not exhaling the total volume through it, you're not going to be picking up the humidity to be delivered to the patient on the next breath. So I'm not saying you can't utilize a heat and moisture exchanger, but it tends to be less efficient in humidifying because of the leaks. Remember, every one of these has a limit to the volume that it can humidify. Most say that 700 to 1 liter is the optimal volume for humidifying the gas to whatever the defined humidity level, which in most is around a water vapor content of about 30 milligrams per liter. So you can get away with it in some patients, but I would be very cautious with the use of a heat and moisture exchanger. My own bias is to use an active humidifier in these patients. Today, there are maybe 50 masks out there that you might choose to do non-invasive ventilation, both of the nasal and of the full face mask type. And clearly, there is no one mask that will fit everybody well. I mean, if we look at our own anatomies, each one of us has a different facial anatomy, and a given mask may work well on me, but may work very poorly on you. So different types of masks, different sizes of those masks make it easier to come up with the specific mask that will work well on a given patient. In addition, there are 3 other devices that are available, used less frequently, but clearly things you can use to manage patients non-invasively: the nasal pillows, the total face mask, and the hood or the helmet that is being used now in Europe, and I'm told here, also in China. We do not have this available in the United States. Now, we could spend a lot of time talking about the pros and cons. I'll give you a capsule of my impression of these devices. The most comfortable device is clearly the helmet. You put the helmet on, there's no pressure on your face. If you use continuous flow CPAP, which is what I would recommend if you're using it for CPAP, it's a little noisy. You may have to use earplugs in a given patient. But the concern I have about the helmet is your ability to deal with a large dead space. This acts as a huge capacitor, and there is a potential for accumulation of CO2 in that capacitance. And particularly when you're ventilating a patient, and a patient who presents with severe respiratory acidosis, where you're trying to turn that patient around quickly, this would not be my choice. My choice would be a face mask with a low volume of dead space so that I can rapidly turn around that CO2 level. Having this available after a period of time that the patient stabilized, this may be a better choice from a comfort perspective, but in the acute respiratory failure patient, my choice would be the simple oral nasal mask. The total face mask works well also, but it's got a big dead space again. It takes a little bit longer to alter an acute respiratory acidosis. So depending on the set of circumstances, with CPAP, I'm told in those that use this works extremely well for CPAP. But You have to use a continuous flow system with adequate flow to clear the CO2. Simply using the ventilator to provide CPAP tends to allow CO2 to rise with the helmet. But the more different masks or different appliances you have available, of course, the greater the likelihood you'll find the one that will work best on a given patient. Let me finish with this study that we now published a couple years ago in Respiratory Care. We looked at these non-invasive ventilators to get an idea, when you titrate oxygen into the system, actually how much O2 the patient receives. Very commonly done in many settings, because there's only one of these devices that I'm aware of that allows you to give a relatively precise FiO2. Every one, you have to titrate O2 into the single limb circuit. So we used a lung model. We had 3 different leak ports, one in the mask. We used the plateau exhalation valve, and then the exhalation port in the circuit itself. Numerous settings of the ventilator, 2 respiratory rates, O2 added in 2 different positions, in the mask and in the circuit, and then 2 different liter flows of O2. And this is what the setup essentially looked like. So we added O2 here as it left the ventilator, or we added O2 in the mask and used a spontaneously breathing lung model to generate inspiratory effort. FiO2, as you might expect, was unaffected by the respiratory rate. We didn't have a high enough respiratory rate to overwhelm the actual flow of gas into the system. Leak port in the mask. The FiO2 was greatest if O2 was added into the circuit. So if the exhalation port was here, it was best to add O2 back at the ventilator itself and not close to the mask, allowing for a bigger reservoir of O2 during the inspiratory phase. Leak port in the circuit or a plateau exhalation valve, you got the highest FiO2 if you added O2 in the mask. In other words, if the expiratory port was here in the circuit, then adding O2 in the mask allowed it to accumulate in the mask in the short amount of rebreathed tubing and allowed you to get a higher FiO2. Although, when the leak port was in the mask itself, regardless of configuration, we had the lowest FiO2. FiO2 decreased as we changed the settings, or increased if you went downward on the settings. Remember, as you increase either the pressure support or the PEEP level on these devices, you increase flow. So if you have a fixed flow of oxygen coming into the system, you're going to affect the FiO2. And as you'd expect, FiO2 increased when flow increased. I put this up here to give you the extremes of what we measured. The lowest FiO2, 22%. Leak port in the mask, O2 flow added to the system, 5 liters per minute, oxygen delivered into the mask. So you had the leak port in the mask, oxygen delivered into the mask, and the highest setting on the mechanical ventilator, virtually no oxygen delivered to the patient. Even when we dropped it to the lowest settings, we had minimal increase in the FiO2 with this type of configuration. The highest FiO2 was with the leak port in the circuit, high flow, 10 liters of oxygen into the mask itself, and the lowest setting on the BiPAP. In other words, 78%, a tremendous amount of variability, increasing to the highest settings on the ventilator, 40%. The takeaway message: you have no idea what you're doing when you add oxygen and titrate it into these systems, is what I'd like you to go away with. If you're using these type of systems on critically ill patients, particularly those who require an FiO2, and you're trying to titrate that oxygen into the circuit, you really have no idea what FiO2 the patient is receiving. And part of the problem in the patient's tolerance may be simply that particular factor. So I think it's important, again, to keep that in mind as you're utilizing these types of devices that are not necessarily designed for critically ill patients in the intensive care unit on somebody you're trying to avoid intubation. Thank you.
Thank you very much for your excellent presentation. We may spend just a few minutes for questions. Any questions from audience?
Robert,
Yes.
This is Dao Yu from China. I'm wondering, is it possible to use laryngeal mask instead of facial mask and nasal mask to do the non-invasive ventilation? For the patient have a short stage in ICU to do that.
I missed the first comment. The what kind of mask?
Laryngeal mask, Lima.
A laryngeal mask airway?
Yes.
We have never tried to use a laryngeal mask airway for non-invasive ventilation, so I can't say for sure. Now, in the operating room, people use them all the time, but they don't come back to the ICU. I mean, I don't know if anybody's I don't have personally experience with using a laryngeal mask airway. And the way that airway is designed, it is not designed for a non-invasive ventilator. You can ventilate patients through it, as you well know, so you can continue ventilation. But it's a relatively unstable airway, and without somebody at the bedside who knows how to deal with that on a continuous basis, as in the operating room, I'm not sure it's a stable enough airway to use in the intensive care unit for a patient who may still be, I assume, partially sedated post-anesthesia. It seems like they need to be in the setting where they can be carefully monitored and cared for by individuals with familiarity with that device. But I must admit, I've never tried, we've never used it in the intensive care unit. Patients came to the OR who may have used it, they've always been intubated, and we've continued ventilation invasively instead of trying to maintain it non-invasively with the laryngeal mask airway.
Okay, thank you, Dr. Ball.
Robert, what is pillow mask? Pillow, and your discipline different.
The nasal pillows are available from a couple different manufacturers have it. Where I find it most useful is a patient we send home who's receiving some type of non-invasive ventilation, where you can have the patient switch off from a mask, either a nasal mask or a full face mask, to the nasal pillows. It puts the pressure at a very different location, and those patients continuously using non-invasive ventilation or CPAP at home find that it works really well, as if not continuously, but as a alternate form of mask for a couple days while they allow pressure points from a regular face mask to improve. So you can find it out there, from a couple of different manufacturers. It works pretty well. If the patient can be ventilated nasally, the nasal pillows work well, and in my own assessment on myself, they're relatively comfortable, more comfortable than a nasal mask.
Next. From back.
Okay, I have two questions. The first is, some patients, some COPD patients with respiratory failure are not conscious enough. And in this case, some pulmonologists still recommend or even encourage the use of non-invasive ventilation, even if the patients are not conscious and cooperative enough. And is there any real advantage by doing this? What's your opinion regarding this? And can I speak out my second question?
Sure.
Okay, my second question is, when you use a typical non-invasive ventilator, and is it possible or useful to measure the end-tidal CO2? You see, I try to measure the EtCO2 when I use a non-invasive ventilator, and actually the capnograph waveform I got was very poor. I don't think it's accurate enough. I don't think it's accurate. The measured EtCO2 value was accurate enough. So do you have any experience in this regard? Okay, thank you.
The second one's easier to answer. I would say no, that trying to look at end-tidal CO2 is very difficult, because as the leak changes, flow from the ventilator changes, and of course the end-tidal CO2 will change even though nothing has occurred with the patient. So we've tried it and found, as you have, that it's relatively useless to try to put a end-tidal CO2 monitor into a non-invasive system. Now, I'm not saying we might not in the future get better masks, better systems where you get more or you get smaller leaks and it works. But current technology, I would say that in the vast majority of the patients, you will get useless information from a end-tidal CO2 monitor. As far as a COPD patient, I'm not sure how to answer that correctly. And let me give you the scenario. We have a COPD patient who comes in who's got a CO2 level of 80 or 90, their pH is 7.2, and the patient is not with it. You know, they're still breathing a little bit, but they're not totally with it. We put them on non-invasive ventilation. You stand there and you put it on them and spend a half hour, 45 minutes, their CO2 comes down to 60, they become alert, they become aware. Now you can strap that mask to the patient's face and let them continue. I would not recommend strapping and leaving a patient who is comatose on non-invasive ventilation, although I may find people who disagree with that and have had success with it. But if you're going to begin non-invasive ventilation, in my opinion, in that type of patient, it mandates you stay there until you are reasonably assured that the patient is now alert enough to deal with any issues of airway protection that might arise as you continue non-invasive ventilation. And to me, that's the major concern I have about strapping a mask, particularly a full face mask, to a patient who's not totally alert and conscious. That if I do get gastric distension, which is not usually an issue, but you never know, you know, and this patient vomits, they have no ability to remove the mask or to respond to it. So yes, if you're standing there at the bedside and monitoring that patient until they're alert, no, if nobody's going to be standing there with that patient who can respond appropriately to any particular concern.